Hi everyone, my name is Meredith McCrory, and today I will be presenting my DNP Poster Project, a multimodal strategy to activate pronation for acute respiratory distress syndrome patients. First, I would like to thank the JSU faculty, especially Dr. Stevens, for their mentoring and support throughout this process. I would also like to dedicate this project and completion of my DNP to my grandmother, who I lost from COVID-19 on January 15, 2021. Acute respiratory distress syndrome, or ARDS, affects 190,000 individuals in the United States annually and carries an overall mortality rate of 30 to 40%. The clinical course of this disease is highlighted by acute hypoxic respiratory failure, evidenced by chest radiographs revealing bilateral dense consolidations. Manual pronation of ARDS has shown an increase in alveolar function with end expiratory lung volume, which leads to the improvement in oxygenation and rate of survival. At my DNP project site, a protocol is not currently in use for pronation with an ARDS diagnosis and carries a mortality rate of 90%. The purpose of this project is to increase pronation for patients diagnosed with ARDS through implementation of a standardized protocol. My PICO for this project attempts to answer the question, in patients with ARDS on mechanical ventilation, does the implementation of a standard pronation protocol compared to a lack of a standard pronation protocol increase the rate of pronation? This quality improvement project was designed and implemented by adopting an evidence-based standardized protocol that could be used in both the medical intensive care and cardiac care units. The protocol will include a standard operating procedure, or SOP, checklist, and proning kits. This protocol will provide a detailed outline process for pronation and supination. And on top of the protocol, there were opportunities for additional learning, including classroom-style sessions that included an overview of the SOP, checklist, and the equipment needed for pronation. There were also simulation scenarios to give opportunities for hands-on learning for the healthcare staff. This quality improvement project was implemented from start to finish over a 3-month time period and observed all patients with ARDS who met criteria and were proned. Prior to implementation, an extensive literature review was conducted. In the Proning Severe ARDS Patients, or the PROSEVA trial, which was published in 2013, found patients with severe ARDS were randomized either prone positioning for 16 hours or left in a supine position. In summary, proning significantly reduced mortality rate at the 28 and 90-day mark compared to leaving the patients in a supinated position. It added to the growing body of evidence that prone positioning improves survival in severe ARDS. Prone patients were also successfully extubated at a higher rate and required fewer days of ventilation when compared to supine patients. At the American and European Consensus Conference, or the AECC, which occurred in 1994, an initial criteria was developed for ARDS. It was developed that included rapid onset, chest X-ray revealing bilateral opacities, detrimental hypoxemia, and no evidence of heart failure. The AECC's definition was the benchmark for over 20 years until the development of the Berlin criteria in 2012, which includes timing of symptoms, chest imaging, edema, and oxygenation. Protocols and checklists for the process of pronation play an important role in the overall success of pronation adherence. This protocol and checklist should outline the process step by step to ensure the safety of the intubated patient when placed in a prone position. Per Giovanni et al., studies specifically focused on knowledge transfer in critical care suggest benefit in using a combination of protocols, guidelines, or bundles with or without education to implement the best practice in the ICU. Along with protocols and checklists, simulation also plays an important role in the ICU education. When utilizing simulation, this gives the learners the opportunity to identify potential errors that could affect patient outcomes and care. When using protocols, checklists, and simulation, There's a focus on promoting knowledge and practical implementation of pronation. Following the implementation of the pronation protocol, checklists were used to assist and guide healthcare staff during the process. Each pronation experience was dated and timed. Data collection spreadsheets tracked admissions, diagnosis of ARDS, intubation, pronation dates, and any complications related to the pronating process. The rates of pronation were compared pre and post implementation. Pre-implementation of the protocol, only COVID-19 patients were proned. This left a 55% gap of ARDS patients who met criteria for pronation but were treated in a strictly supine position. Post-implementation of the protocol, the census was unusually low in both units, leading to a small sample size. However, following the implementation, it was found 100% rate of pronation among ARDS patients. Due to ongoing therapies, the mortality rate could not be calculated post-implementation. In conclusion, by implementing a pronation protocol, there's an increased rate of pronation. However, due to the small sample size, there's recommendation for continuation observations of ARDS diagnosis and pronation in both the units. Continued collaboration with healthcare providers to ensure that new employees have the learning opportunities for pronation. Findings from the project were disseminated to the executive leadership team with hopes to expand this protocol to the other unit. It's my goal to have other facilities within our region use this protocol. This is the conclusion of my DNP presentation. If you have any questions, please let me know.